The ankle brachial index, or ABI, is a means of assessing for peripheral arterial disease within the office setting. There are two methods to obtain the measurement. One is with the use of Doppler, which is the gold standard at this time, and the second requires the use of an automated or oscillometric blood pressure device. In this video, we'll be discussing the Doppler technique, but if you refer to the link below, you will be forwarded to the oscillometric ABI measurement technique.
So, why should we assess ABIs? Peripheral arterial disease affects approximately 800,000 Canadians. Over 50% of these patients are asymptomatic, which is important as research demonstrates that patients who are asymptomatic with an abnormal ABI have poorer cardiovascular disease outcomes than patients with normal ABIs. Most recent meta-analyses show that the sensitivity and specificity of an abnormal Doppler ABI to identify greater than 50% arterial stenosis are 75% and 86% respectively.
Risk factors for PAD include smoking, diabetes, hypertension, dyslipidemia, advanced age, and family history. ABIs should be used to evaluate lower extremity ischemia in patients presenting with claudication, breast pain, or foot ulcers. It can also be used as part of cardiovascular risk stratification, safety assessment for compression stockings, and evaluation of lower extremity trauma.
There are no absolute contraindications for ABI assessment. Nevertheless, it is best to avoid its use in patients with severe leg pain, suspected DVT, or in those with distal bypass graft. So here's what you'll need to do the procedure. So you need a sphygmomanometer, a handheld Doppler, and ultrasound gel. Much of the current literature does support the use of an 8 to 10 megahertz pencil probe. However, there have been anecdotal reports of the use of a 2 to 3 megahertz obstetrical probe. This is mainly just due to ease of access.
To begin, ensure the patient has not smoked for at least 2 hours prior to measurement and that they are in a supine, comfortable position for approximately 5 minutes with both their head and their heel supported, and that their arm is at the level of the heart. Select an appropriately sized cuff for both the arm and the ankle, ensuring that the width of the bladder is at least 40% of the limb circumference.
The procedure follows a counterclockwise direction. So starting at the right arm, then moving to the right leg, and left arm. So start by applying the cuff to the right arm, then palpate the brachial artery and mark its location.
Apply gel to the probe and place the probe at the area of the palpated pulse at an angle of 45 to 60 degrees directed towards the head. Inflate the cuff to 20 millimeters of mercury above the point of signal loss. Then slowly deflate the cuff at a rate of about 2 to 3 millimeters of mercury per second until the signal returns. Record this as the right arm systolic blood pressure.
Next, move to the right leg. Apply the cuff 2 centimeters above the medial malleolus. Palpate and mark the posterior tibial artery and repeat the same process to obtain its systolic pressure. Repeat this process for the dorsalis pedis artery and record its pressure separately. To complete the procedure, repeat the same Doppler assessment for the left leg and arm.
To calculate the ABIs, you will require the higher values of the posterior tibial and dorsalis pedis artery pressures for each leg, as well as the highest of 2 brachial artery pressures. Divide each respective ankle pressure by the brachial pressure. For example, for our patient, he had a higher right arm pressure, right dorsalis pedis artery, and left posterior tibial artery pressure. So his calculation would be as follows.
So based on the current literature and the latest American Heart Association guidelines, the following are the accepted ranges for ABI interpretation. Values greater than 1.4 indicate incompressible vessels, which are more common in individuals with diabetes and chronic kidney disease. Individuals with an ABI greater than 1.4 have an increased risk of amputation and cardiovascular events, and they should be further investigated with CT angio or duplex ultrasound. Values between 1.0 and 1.4 are considered normal, Values between 0.91 and 0.99 are classified as borderline. So these individuals do remain at risk of PAD and critical limb ischemia, and they're recommended by the American Heart Association to undergo ABI testing following exercise. Values less than 0.9 are diagnostic of PAD, so these individuals should be further investigated with CT angiography and duplex ultrasound.
But remember, these are guidelines, and your ABI assessment should be used in conjunction with your clinical assessment.